So today we are going to talk about the ST segment. This is one of the most important part of the ECG, as the ST abnormalities, that is ST depression or elevation, that represents the ischemia or the infarction. So what is the ST segment? Actually, it is the flat isoelectric line between the end of the S and the beginning of the T wave. Let me show you over here. Okay, so here is your QRS. So end of the QRS and the beginning of the T, this portion is called ST segment, and you have to look that one whether it's elevated or not. So how you gonna compare? Okay, do you have any isoelectric line with whom you're gonna compare that whether it's elevated or not? Yes. Okay, let's see it there. Okay, so actually, you need to compare that one with this is T wave, at the end of the T to the start of the next P. This is called TP segment. Okay, so you have to compare this one with the TP segment. Say, for example, if I have to look at this S2 segment, whether that's elevated or not, I have to compare with this TP segment over here. Okay, why we are choosing the TP segment and not the PR segment? Okay, because this TP segment, um, it's always at the baseline and is used as a reference to determine the ST elevation or the depression, because this is in as there's no specific disease in which this TP segment goes up or down. Okay, yeah, PR segment, there are some diseases in which, like the pericarditis, in which the PR segment is depressed, or the atrial ischemia, where it can be depressed or elevated. So that's not a good, actually, the baseline to see the ST segment elevation. Rather, you should compare it with the TP segment. Okay, this is TP segment over here. Okay, and you compare this ST with this TP segment over here. This is how on a real ECG you can look at this TP segment. Okay, and you can compare this ST okay with this TP segment. Okay, this baseline, that whether it's elevated or depressed. So let's talk about first the ST elevation. So the rule is actually that the ST elevation, well, I'm gonna say that the ST is elevated as far as the ischemia, the infarctions is concerned. ST elevation is 1 mm in two contiguous leads. Okay, that is significant. 1 mm in two contiguous leads, that is significant, except the lead V2 and V3. For the lead 2 and V3, we have the separate criteria. In lead V2 and V3, in the females, okay, it should be 1.5 mm. Okay, in V2 and V3. For the males, it is if they are less than 40, then 2.5, and if they are greater than 40 years old, then 2 mm in V2 and V3 would be significant. So here you can see that if you see at the lead 2 and 3, okay, and the AVF as well. Okay, this is our TP segment here. Let me change the color. So this is a TP segment. Okay, TP segment, and that's our baseline. So we're going to compare this ST segment. Here is the ST segment with this one. So it's elevated. Okay, it's elevated. Here we can see it's elevated. In the lead V3, lead 3, you can clearly see that it's elevated. Okay, so ST segment is elevated over here. In the AVF, if you're going to see that, that's also elevated. Okay, it's 1 mm elevated over here. Yeah, 1 mm over here as well, 1 mm in the lead 2 as well. So that's why ST elevation. Here you can see the elevations over here and the depressions here. Actually, what happens then whenever there is a ST elevation MI, there are the reciprocal ST depression in the other leads as well. As far as the interior wall and the lateral wall MI is concerned, the reciprocal changes, okay, these depressions and the T invariant, you can see in inferior wall MI, in the inferior leads. Okay, in the interior wall MI and the lateral wall MI, you can see the reciprocal changes in the inferior leads. Okay, and in the inferior wall MI, you're gonna see these reciprocal ST depressions in interior leads. Okay, here in this ECG, you can see again, okay, this is 2-3 AVF, that's inferior wall MI, okay, and the reciprocal changes you are seeing here in interior leads V2 and V3, okay. There's a depression, ST depression over here. In contrast to that, you can see that it's interior wall MI, okay, V2 and V3, if you see that one, okay. So here the reciprocal changes you can see over here in the inferior leads, okay, 2, 3, and AVF. There's ST depression over here. Let's discuss about the causes of the ST elevation. You know, it's STEMI, that's ST elevation MI, Prince metal angina, the pericarditis. But in the pericarditis, there is diffuse ST elevation. Okay, you're gonna see in almost all the leads there will be the ST elevation, more than one. And then benign early repolarization, ventricular aneurysm, sometimes a raised intracranial pressure, Brugada syndrome. There are also the less common causes of the ST elevation, like the hyperkalemia, hypothermia, sometimes the acute aortic dissection. Particularly, that how that's going to give ST elevation. That's going to lead to inferior wall MI if the RC is actually dissected. So that's going to give the ST elevation as well. Let's talk about the ST depression now. So, what's the criteria for the ST depression? That is 0.5 mm in two contiguous leads. Again, 0.5 mm in two contiguous leads, and that should be downsloping or the horizontal. Actually, there are the three types of ST depression. That's upsloping, okay, that's like upsloping, downsloping, or the horizontal. So here you can see actually the three types of ST depression. Okay, if we look at the first, this is upsloping. Okay, this is upsloping ST depression. Okay, the next one is downsloping ST depression, and the third one is horizontal um, ST depression. So 0.5 mm of the ST depression in two contiguous leads, and that should be downsloping or the horizontal ST depression. Okay, because this upsloping, okay, this is not very specific for the ischemia. The most specific ST depression is actually the horizontal type, followed by, this is the number one, followed by the downsloping. Okay, so downsloping are the horizontal 0.5 mm in two contiguous leads. Let me show you this upsloping, downsloping, and the horizontal in a real ECG strip. Here you can see clearly, okay, this is an upsloping, okay, ST depression. This you find in the SVT sometimes, okay, when the heart rate is too fast. Okay, that's why it is the least specific. Then it's downsloping, okay, and it's a horizontal. Okay, the horizontal has the least error rate, okay, followed by the downsloping. Here you can see again, okay, it's a down sloping, the horizontal, and the upsloping ST segment. Here you can see there's a type of ST depression. So here you see there's upsloping, okay, that has 30 to 40% of the error rate. The horizontal, okay, that is actually that's very low, the error rate is very low, and this is the downsloping, okay, that comes after the horizontal. ST depression 0.5 mm, okay, though it's 1 mm is written over here, but actually it's 0.5 mm in two contiguous plates. Now let's talk about the causes of the ST segment depression. The ST segment depression that represents actually the subendocardial ischemia. So could be in the unstable angina and STEMI. Okay, in unstable angina, if the patient is presenting with the pain, in NSTEMI, okay, it could be in the reciprocal changes, as we have said earlier. Okay, there are the reciprocal ST segment depression, okay, according to the type of the MI. Okay, it could be in the LVH, that's left ventricular hypertrophy, right ventricular hypertrophy, left bundle branch block, right bundle branch block. It could be, as I said earlier, in the SVT, upsloping ST depression, in the digoxin effect, hypokalemia. Widespread ST elevation can be seen in particularly a dangerous condition, that is left main coronary artery occlusion as well. So that's all about the ST elevation or the ST depression. We will be discussing the pericarditis and the other things like procauda and digoxin effects, and we have talked about a little other things as well, the ventricular aneurysms and the Prince metal angina, benign early repolarization in separate videos.